Allogeneic hematopoietic stem cell transplantation is very rarely used in myeloma these days, and we have some data from a phase 2 multi-center study in the US that will be reported out fairly soon at ASCO, hopefully in 2021. However, it used to be an option that was pretty much restricted to young patients with ultra-high-risk disease. Immunotherapy in a more sophisticated fashion, whether it's going to be with CAR T cells or bispecific engagers, I think will seriously challenge and perhaps completely displace allogeneic transplant. Having said that, we don't know if anything in therapeutic trials right now will cure myeloma, and allogeneic transplant, especially for the younger patients, does hold out the promise of a cure, although in a minority of patients. So I think allogeneic transplant is probably on its way out, and newer forms of immunotherapy that are much more sophisticated and much more tolerable to the patient are coming in. And that makes it applicable broadly, even outside of the young patient who could have gotten an allo transplant. This becomes much more applicable even to older patients, which is the majority of patients in myeloma. So the autologous transplantation is still the majority of transplant for myeloma, the vast majority. In fact, some 7,000 to 8,000 transplants are being done annually in the US for myeloma with auto transplant. And with regards to auto transplant, I think this ASH, they had a session that was entitled "Autologous Transplant is the backbone of upfront therapy in myeloma." That perhaps was probably the most aptly named session of all of ASH that I saw. And it showed a plethora of findings. So the most important among these findings was the update of the IFM 2009 study that compared upfront autologous transplant versus VRD consolidation and maintenance. And in that study, consistent with the previous results, it just established that progression-free survival was superior if autologous transplant is used as an upfront therapy. In fact, patients live a longer disease-free first remission if they do an upfront transplant in their first remission. And in the patients who deferred the upfront transplant, they could, in fact, the vast majority of them did end up getting the transplantation when they relapsed. But this relapse was sooner than they would have had if they had received the upfront transplant. So that was the finding of that study. And then we also saw the results of the Forte study, which is a large study that compared KRD induction with or without transplantation, and also a different induction with KCD. And when the study was initially read out with short follow-up, it appeared that the deep remission rate or the MRD negative remission rates were irrespective of transplant, were good for KRD for 12 cycles, and it was just as good as transplant. However, now with longer follow-up, it turns out that if you undergo a transplant in their first remission, you enjoy a longer progression-free survival. And that was also a significant finding from this ASH. In addition, we had a couple of other longer European studies that reported out the benefit in terms of progression-free survival for patients who undergo an upfront auto transplant. So I think the role of autologous transplant in myeloma is pretty much solid at this time. I think CAR T cells will start challenging that role, or bispecific engagers, or some of the newer drugs, any of them, it's it's up for grabs, that space. However, transplant still remains the fastest and the cheapest, in fact, way of getting to a deep MRD negative remission. And as we know from all of these studies, a long first remission is the backbone of a long life with myeloma. And the best way to get a long first remission is to use an upfront transplant.